Good afternoon and welcome to this concurrent session. In this session, we will be listening to an NHI panel discussion, which is going to be facilitated by Alex Brownlee. Thank you very much.
Thank you very much. Welcome, everybody. Firstly, thank you to all the panelists for their time. We're really aiming to kind of get some diverse external expert views on the NHI and all of its dynamics around that. And I'm very pleased to introduce the panelists. Just briefly, because their CVs are quite long, but Mr. Russell Rensburg, Executive Director of the Rural Health Advocacy Project, is a health activist, really advocates for equitable access to healthcare, particularly in the rural communities. He's also the co-chair of the SANAC TB Technical Task Team, amongst various other positions. Then Ms. Tempelethu Buthelezi, she's a competition economist, a principal in the competition and regulatory economics practice at Genesis Analytics. She's got significant experience in competition law and economics. Prior to that, she worked for nearly a decade in the Competition Commission, rising to the position of principal economist in the Economic Research Bureau. Then we got Professor Eric Buch, a prominent academic public health specialist, known for his expertise in health policy and management. He's the CEO of the Colleges of Medicine of South Africa and various other positions, but today speaks in the capacity of his position at the University of Pretoria. But certainly has a career spanning over 30 years in various roles within academic, government, and non-government organizations. And last but not least, Mr. Andrew Donaldson. He's a prominent economist and former senior public servant known for his long career in the National Treasury. Since Treasury, he's returned to academia and research at the University of Cape Town. Welcome, thank you for your time. The way we'll structure today is we've only got an hour, so I'll try to create kind of a panel discussion through sort of question and answer for the panelists. Unfortunately, not all of them will be able to answer everything, so we'll see how we go. We'll try and provide some time to use the audience at the end for questions and answer session, and then hopefully give the panelists a sort of a closing remarks within the 1 hour and less time slot. To reset the context, let's start with the question of equity. And perhaps, Mr. Rensburg, I'll start with you. So in your view, what are the current equity issues as it relates to access to quality healthcare for all South Africans?
I suppose that's the 500 billion rand question around what is the responsibility of the state in leading health reforms. I think I should start with the constitutional arrangements there, or obligations that we place ourselves under Section 27, where as South Africa we're quite unique in guaranteeing everybody access to healthcare, but we have a caveat to progressively realize that over time. So part of the problem that since the publication of the National Health Act in 2002, even though we make provision for the minister to declare some kind of package, we don't have a baseline for how we progressively expand it. So for the last 20 years, we kind of have a free-for-all kind of system where the public sector is the health provider of last resort for insured and uninsured people. The net result is that even just on that 295 billion that we spend on public funded healthcare, it's skewed towards higher LSMs, where 65% of the spending is happening at higher level hospital services, and less money is progressively spent on broader primary healthcare. When we take that back to where we are now in 2025, when our population is quite youthful, our public sector system is more of a care system. It doesn't necessarily respond to the day-to-day healthcare needs of the population at large. And I think now we have to sit at a process with a different political economy to start saying, okay, what does it mean in respect of Section 27? What are the health entitlements that everybody is responsible for? And how do we start charting a path for progressive realization so that we can actually have universal access? Now we start with universal health coverage, but can we have universal access over the long run? And I think that requires a rearrangement of how things are financed so that we can have a clearer path to what we mean by progressive realization. So for me, it starts off with universal health coverage, which is the three main priorities, is maternal and child health, right? And look at measures of effective coverage around that. There's 1 million women that give birth in the public sector, 200,000 elsewhere. Infectious diseases, which is our biggest crisis at the moment. Post the events in January, it kind of shapes the public sector. If we don't stabilize it in some way or find different ways of doing it, we could have a bigger crisis than what we had in 2002. So infectious diseases is HIV and tuberculosis. And then the thing that everybody's worried about at the moment is non-communicable diseases, where in the public sector we sort of have how can you say, like first come, first serve basis as to who gets managed. And you can take an example like diabetes, where we only have modeled estimates, but around 4.5 million people live with diabetes. Only 1.2 million of them are in care. Probably 80% of those are in the private sector. So just on those base things, there's inequity. And our current system is not structured really to address it. So I think the NHI, in my view, is an attempt to start that process of a defined healthcare package that the state can afford and then progressively expand so that it covers everything. But in the last 20 years, we haven't had that progression. Thank you.
Thanks. Maybe Professor Buch, I see you can
answer
as well. Yes.
We've only got an hour, and the answer is very simple. 30 years into democracy, inequity is the defining feature of our health system. There's inequity in access between rural and urban, between private and public, and all the other characteristics. We haven't, that remains a defining feature of the health system in terms of access to quality care and equity.
Thanks. Yeah. So I think there's kind of wide scale agreement around the kind of moral directive to improve the healthcare system for all. So I think that's the equity. And let's just jump into the NHI Act then. So it does stipulate a single fund to collect the funds, the pool, the taxation, and then procure healthcare services on behalf of the population, procure being contract and pay for them. That can be done into the private and public sector. It does talk about, once it offers those benefits that medical schemes cannot. But essentially one of the big topics in the press that we've seen is the issue of the single fund. So perhaps, maybe move to Mr. Donaldson and then Ms. Buthelezi. This question of the single fund, are there benefits and risk of a single versus multiple fund? Mr. Donaldson?
There's an obvious sense in which a single fund has the potential to be more cost-effective than a multi-fund environment, and that's an important reason why the World Health Organization generally favors single fund models. But our problem, given our history, is that it's extraordinarily difficult to describe a transition path from the system we have at present, the balance between public and private services and the multi-fund medical schemes environment alongside public health services, to a single fund. And when you really look at international systems, although we think there are single fund systems in places like the UK with an NHS, some of the Southeast Asian countries have a dominant single fund that dominates services. The reality is every country has many systems. Even the OECD systems that have largely integrated policies have universal access. In European models, typically multi-fund environments that go back to old occupational arrangements in the 19th century or the early 20th century. Even in these systems, there are state-funded arrangements alongside privately managed arrangements alongside payment out of pocket. And looking at South Africa's history with the extraordinary administrative capacity that we've built in our medical schemes environment, it does seem to me that a more rational path forward is to build on that, is to expand membership within our medical schemes environment so that we reach a stage when 40% or 50% of the population are covered through a multi-fund system, and it becomes much more realistic to think in terms of how you could level the playing field between them.
Thanks. We'll probably get a bit more into that detail. But Ms. Buthelezi, just in terms of your view of a single versus multi-fund benefits, pros and cons?
Sure. I think There is a lot to say, and I think I agree with Andrew in terms of some of the benefits you can think through a single fund. But maybe what I would like to maybe stress through is, firstly, what a single fund can do is, in a way, maximize social solidarity, because in a way, a single pool can dramatically give quite high benefits for income and risk cross-subsidization. And obviously you can leverage quite a bit in terms of monopsony power and just larger bargaining power that a single fund allows for. What we've also learned is that with a single fund, and just from some of the thinking, is that it could also allow for what in terms of a two-tiered sector that South Africa has had for a while, is to eliminate some of these negative externalities or spillover effects that may be observed just from the existence of, I guess, a private sector with a higher per capita spend that is able to draw higher human resources and inputs away from the public sector. And these are just some of the big picture principles and benefits that we've understood, at least in terms of informing this design of a single fund. But obviously they have quite significant risks, right? And could only work if at that maximum point you are able to benefit from the full design in terms of governance and equity and the like. And I think a lot of our work and our analysis does show that a particular structure, so the single fund structure, can also significantly affect equity in terms of access, which would be in a way against what the NHI Act would intend to do. And so while it may intend to achieve or aims to achieve almost a vertical equity, what we found is that through a single fund, and given the severe type of fiscal constraints, and I think we'll go into this a lot more later, is that what you do see is that while there is some kind of vertical equity, so a redistribution from rich to poor in terms of financial implications, there is a reduction in access, particularly for those that are currently insured. And that, in a way, starts to shift the debate a little bit more about the full benefits you could get from a single fund.
Thanks. I think, Mr. Rensburg, you want to add?
Look, I suppose we can deal with abstractions, right? We can't put the cat back in the box. Inequity is a binding constraint in South Africa. We have a universal public system, but not universal access. If we consolidate just public sector funding, it's 295 billion, would make it the largest fund, and just by being the largest fund, it would be able to influence all other funds. But I think where the inefficiency in the current multi-fund environment comes in is that we're not working off a uniform framework. So we have multiple funds running multiple different schemes, each with its own efficiencies. They can't pool any of their resources, share their risks. So each fund almost has to run its own efficiency, and it benefits what we have in our system, where we have two primary big players that shift the market and a whole lot of other ineffectual schemes. I think what would be useful, though, if we look at the total envelope of money that we have available and the population that we're serving, is to think of this in a progressive way. So if we start thinking about solving the public sector problem, right, how do we utilize the money that's already tax funded, and what I think the fund is primarily geared towards in most of its provisions, is to strengthen and reorganize the public sector. Right? So we have 9 different provincial health administrations, each running their own funds, in inverted commas, doing the same thing. Right? We have a national system that has very limited regulatory engagement around managing of funds and prioritization. Right? So if you look at the National Health Act, one of the things that they describe is that we must have at least provision of comprehensive primary healthcare services. It makes like a provision in Chapter 5 for the provision of specialized services, but specialized services dominate how we spend. So if we take a step back and we say, let's start with the design of a uniform health package that everybody has to deliver and can be funded in whatever way, right? So we may not start with a single fund on Monday, but we start with a universal framework of primary health care that everybody can fund. The schemes can compete on the risk, and we can start working on how do we improve efficiencies, not just at the scheme level, but on the sector level. Over the long run, we can arrive at Andrew's destination in the same way, where we can automatically, like it has in Australia or in the Netherlands, where there's 2 major players in the health fund, down from 15. The rationalities come over time. But we have to focus on the problem that we're trying to solve, and I think that's really expanding healthcare coverage for the vast majority of the population, making sure that we have a basic minimum package that everybody can achieve. And then schemes can price accordingly to the populations that they serve, because we're very far away from the NHI becoming the only thing. But I think we close our minds when we start thinking about the end destination, which is maybe 20 years ago, and we miss out on the opportunities now, particularly in an environment where we have limited fiscal space, to manage the public sector better, to the benefit of the public as well as to the medical scheme environments, where there can also be some consolidation on what is covered and how it's covered. Right? So I think we need to be a little bit creative, which is something I know actually is very good at. And I think that's what we need to reflect on. What is the bigger picture we're trying to solve? And then how do we work from where we are now instead of continuing with these different stalls on the market? So I don't think we have to look at it just in a technical way.
Thanks. I think what I've picked up between the conversations is the kind of the reality, the practicalities. There's this kind of the equity directive that we need to improve and achieve. And certainly it makes me think of the kind of equity discussions. There certainly are frameworks where equity is not the kind of perfect ideology. The NHI fund is a separate conversation from what you're trying to achieve, and how you achieve it is there's different pathways and timelines, and there are risks, as mentioned. So certainly we're touching on kind of practicalities, and maybe just unpack that a little bit further. Let's just talk about the operational ability, and maybe just kick off with Ms. Buthelezi on this. Let's just talk about the NHI Act in its totality, if that was implemented relatively quickly. What's the operational ability of government to do that? I'm talking not just operational, but also legislative, as well as the kind of governance aspects. If you could perhaps just share some thoughts on that.
Sure. I think I'll be limited in terms of just financial and I guess resource implications, and then on the governance, I think the other panelists can add in. So how we considered this was obviously, so government has come out with a broad principle in terms of comprehensive care for all, but has realized that there is quite a tight budget in achieving that. So a more realistic consideration of what can be done with the Act would be, let's take what we have already in the system and just pool that financial resources and share it equitably amongst South Africans. So-called a shared spend type model. And a lot of my thoughts are obviously going to be informed by that in terms of what implications that has. So I think I've already touched on the fact that even under this point, there is a reduction in access and obviously some impact in terms of quality of care. But just to give some numbers to this, to almost crystallize the idea, I think in terms of the universe, or in terms of 2020 terms, in terms of health expenditure or the health budget, we're talking about a 532 billion that can be accessible right now. So even if we think of a world without additional tax increases and the like, let's take what's in the private sector and what government's currently spending in the public health, around about 530. So per capita spend, that means about an 8,600 per person for the whole of South Africa, which is a moderate increase for those that have not been insured, about a 20% increase, or not even moderate, I think quite an increase in terms of access, but has an access impact on medical scheme members of about a 43%. Now, what this means in terms of financial implications for the for the state is obviously an increase in government expenditure, but also importantly an increase in personal income tax, even for those that are not insured. This also has resource implications in terms of the services that South Africans may achieve. So what does it mean in terms of general practitioners, how many GPs we may need, the number of nursing capacity, specialists, hospital beds, and all of that has to also come online. And this is obviously, and these numbers that I'm going through are obviously thought through in terms of even just efficiency, benefits that are associated, even with the fund, leveraging its full powers as a single fund. So in terms of fiscal, operational likelihood of this happening, I think politely it's tight. And it's hard because while there will be and is likely to have an impact in terms of household impact, in terms of financial sustainability, I think this is all also happening in the context of quite a low economic growth in the country. And if resourcing, operational capacity, the regulatory gap, the private sector not being sorted out, all of that lagging behind, I think it makes it quite unsustainable to see how this would work in a way that it's currently being envisioned to take place.
So maybe just to summarize, you sort of touched on the kind of tax and fiscal challenges to try to get it implemented. And just to, if I get it right, you quoted the 530-odd billion. Roughly half is in the private sector, if I'm correct. And,
more than half.
And that's mostly post-tax voluntary spend, right? Because we've got the 30-odd billion, which is the tax credit.
Tax credit, yes.
Then there's obviously some other areas, but otherwise it's voluntary post-tax. And once that becomes an NHI tax, you're saying that makes the tax kind of burden difficult to achieve. I see Mr. Rensburg is shaking his head.
I don't know. I think we get caught up in this calculating thing, and we haven't even got a base package to cost what it would cost to have it distribute or expand its service delivery platform for what the public sector is already delivering. Right? So we're not starting from zero. So if we had to calculate on current, like we do with medical legal claims, and I think Andrew did some great expert testimony in a recent case around how we calculate future life costs in the private sector versus what the public health defense, what it would cost to deliver those same services in the public sector is very different. Right? So I don't think we can really get a sense of what it would be the longer term cost. But there's a lot of efficiencies. Right? At the moment, the public sector already does most of the maternal and child health services for the vast majority of the population, right? For the 1 million people. The cost of delivering babies in the public sector is significantly lower. We can improve the quality, and I think, but if we look at the money that's there, without any new revenue, we can already improve those services with some consolidation. So when we look at the costing, we need to look at that. At the moment, when you talk after tax, we shape it like a discretionary spend, but most of medical scheme payments are conditions of service, right? And I think we have challenges when people have to start funding those, particularly around gig workers who are not in formal employment. If you look at the percentage of those workers who prioritize medical scheme spending, it's a different scenario. So there's lots of risks for the entire market. So I think the whole market as it stands is unsustainable. So we need a different way to expand access, but to keep everybody happy. But I don't think we must over-engineer the costs without looking at where can we find the efficiencies. So the base package, I think if we cost it effectively with a different service delivery model, where the public sector can, for instance, continue to do chronic care, which is does quite well, 6 million people on HIV care, about 200,000 people each year going through very intensive tuberculosis treatment. There's a lot of things that the public sector can do more efficiently if we organize the package and the delivery platforms differently. I think where we have a challenge is with employed people, right? And how can we reduce the costs of these things, like, so we can get more younger people? And I don't think necessarily mandatory insurance is the solution. But if we work off a unified packaging, we can reduce costs for everything. There's other areas of efficiency that I think can benefit both the public, the funders at least, and the private sector. Specialized services. We have a huge challenge at the moment with specialized services, and a lot has got to do with our ability to train more specialists. So we've got a very small pool of specialists who make up probably like 30% or 40% of all medical scheme expenditure as it stands currently, right? And it's a small pool drawing all the money. If we can look at, see if there's a public sector delivery platform like, let's say, the 10 central hospitals that can provide low-cost specialized services to the public and the private sector, we can then afford more money to train more specialists and expand the service coverage so that it's affordable for everyone, including the schemes. Right? So I think we need to stop thinking of these things in a binary, but we can't cost the NHI until the government says this is the package that we're going to guarantee to everybody, and then we can figure out what are the financial costs going forward. But in the interim, we can't take anything away unless we've replaced it. So I think we need to focus our energies more on what could be the base package and how can we improve efficiencies both for everyone in the system, those insured and not insured. Yeah. And I think my last point is, and Andrew can probably throw a lot more color into this, when we calculate how much we spend in the public sector, it's based on the uninsured population. But at higher levels of care, we have people moving between the systems. So the public sector picks up costs that were particularly in the private sector, but people maybe run out of a benefit. They can't afford to pay that out of pocket. and they end up taking up oncology services in the public sector, but they're not necessarily included in the utilization costs for the public sector. So there's a bit of an imbalance. So I think the point is, if we want this thing to work for everybody, we need to start to work with what we have, and then start seeing how we can improve the efficiencies of how we fund it. And in the near term, I think it's really focusing on that first level of district health services up to the first referral hospital. And I think there's benefit both for the schemes and the public sector to look at a unified framework. But the costings without a package, I think, if we're going to base it on somebody else's package, then it's just an abstraction. And I think we create a little confusion in the market.
Maybe I'll ask Mr. Donson just to touch on the cost estimates that have flown around. But, I mean, just the discussion there makes me reflect on really what's been in the press and create the kind of polarized of camps. The one sort of saying, you need technical work, you need the numbers, you need to understand what the package is, you need that detail. And the other side saying, the cost is X number. And it creates that, so there probably is kind of a responsibility of all stakeholders to present debates and information and, in a collaborative way that doesn't sow kind of distrust and division. So certainly a lot of that's been happening in the press, if we think around the bill to the act, etc. So we do need to be, as a society, more responsible in that space. But just, Mr. Donaldson, just on the cost estimates that you've seen thrown around?
So I'm a public finance economist, so I kind of always come back when questions of equity, how much are we spending, how fair is it, questions of social justice come up. It always seems to me that when you dig a little deeper into them, they become questions about prioritization. And in some ways, Russell's initial comments, we talked about rural and urban imbalances, talked about the particular needs of, say, children with disabilities, or so on, is about understanding that equity in the health system is about hugely complex prioritization and distribution issues. At the highest level, it's about the big prioritization challenges that a Minister of Finance in any country faces between health needs, housing, water and sanitation, other areas of public spending that may be absolutely vital for health, improving health outcomes. And so, although we fall, I think, too easily into a presumption that equity in health means a completely equal system in which the same is being spent on everybody, it never means that in practice. And it especially doesn't mean that in practice. This is a kind of paradox of the discourse. It especially doesn't mean that in practice in an unequal society where you've also got to prioritize housing, you've got to prioritize education and the other things that contribute to improving living standards. And so to get to the number, I'm not going to say very much about the costing and the prioritization and the numbers. I'm going to say thinking about what should be done collectively through a public system and what should be left to market-based arrangements or to private insurance arrangements, and how those private insurance arrangements should be regulated, because we know we've learned a lot, partly through the health market inquiry, about how we've still got work to do in the regulatory environment that can contribute to better outcomes. Thinking about these questions has to become much more a question about thinking what's pragmatic, what works best in this environment, what works best in that. So even in systems that rely predominantly on multiple fund arrangements, like the European systems, or catastrophically and archetypally the American health financing system, even in all of these systems, there are things that are funded collectively. In the United States, the basic health insurance package for elderly people is a statutory fund, single fund for everybody, for all Americans. Immunization campaigns are typically collectively funded. Emergency services and a standard package of accident response capabilities can easily be collectively funded across the system, even when there are multiple funds arrangements for other things. And certainly there are areas of health delivery, of dealing with the operational challenges that we were talking about earlier, in which the state is better at doing it and can do things more cost effectively than the private sector. But there are also many things that our public health systems try to do for the vast majority of people that could be better done if we became smarter about bringing private sector administrative capacity, investment capacity, and to get back to your question, which I've not really answered about numbers, then it becomes a question of actually doing the cost-benefit assessments, working out what can be better arranged, more efficiently delivered to more people, dealing with the over-servicing and the things that raise costs unnecessarily in a private health environment, but also dealing with the things in which state services and state-organized services might better take advantage of private capacity. So it becomes about dealing with the complexity, and so I don't have a simple answer to your question.
No, thanks. I mean, I like the concept of prioritization that's been touched on, and that's key. Professor Buch, just to give you the opportunity to perhaps speak to some of these comments and perhaps also just touch on, under the NHI kind of framework, if it is implemented in full, the impact on healthcare professionals. If you want any comments there, certainly they're the backbone of the healthcare system, and it could be their autonomy on clinical decision, their autonomy in terms of where they work, remuneration, etc. So any comments there also welcome.
So a couple of quick comments on the discussion that's just been going is that you asked a question about the single and multiple fund. And I think the answer is that the private sector had failed to build trust in government in its management of the private health sector. Private doctors, private hospitals, private medical schemes. And I think that was the difficult starting point in that space, and I'm happy to talk more to it. I think that one of the things that I think is missing in a lot of the discourse, and we spoke about the polarized debates and the inequity, is that the NHI, there's a lot of focus about whether there should or shouldn't be a regular private medical scheme sector, and you may ask us about that later, and I'll give you my view. But it fundamentally changes the public sector. Because at the moment in the public sector, people get tax-based money as a pot of money. So your hospital gets R1 billion or 500 million rand, regardless of the services you deliver, the efficiency, whether your doctors are disappearing to do private work at 11 in the morning and abandoning the difference here is that the public hospitals will be contracted to provide a certain number of services. If you're contracted to provide 100 hip replacements and you only do 50, and you extrapolate that across also, you'll have half the money for your hospital and half your staff are going to have to be retrenched. That's the theory. I'm not saying it'll the practice. And so what it does is it actually brings a comprehensive change that requires efficiency in the public sector. And I think that often gets overlooked. And it also means there'll be more equitable distribution of budget. So people in the Eastern Cape will suddenly be getting similar amounts per capita to those in the Western Cape and Gauteng, for example, so the equity issue. In terms of the operational ability, I think we've spoken a lot about the ability, the operational ability from a cost and financing perspective. But actually, there's the scale of the fund management that we're talking about. We're talking about the contract management, the contracting between the fund and different district health service providers at primary healthcare level, the different hospitals. That's a massive task. And then, of course, there's the lack of sufficient measures to stay corruption. And the Act in itself does not have enough safeguards against what is a national crisis. So the answer is in theory. The theory says single funds and many other aspects that are there, but a country is not a textbook or a theory. It's a reality, and you have to adapt, I think, as Andrew has said, to the context. But And I think the point that was made about the packages is critical. Because let's say, for example, take renal dialysis. At the moment, most public patients die waiting in the queues for renal dialysis, and when private patients have run out of funds privately and they've sold their house, they move on to the public sector. And so the question is, in the end, you're all familiar in the private sector of prescribed minimum benefits. What happens now is that you mentioned Section 27 says you have the right to the progressive realization of access to health care. So if government can't do it, it's fine as long as you are progressively realizing it. And of course, many communities would win if they took government to court on progressive realization. But the question is, what are you going to do now? Because if renal dialysis is in the package of the NHS, it becomes the equivalent of a prescribed minimum benefit in private medical schemes today, and that means everyone is entitled to it. And therefore, when you cost it, when you look at the capacity, you can't sort of say, well, hang on, there's a prescribed minimum benefit, but some people can get it and some can't, if it's in the package. And that starts to raise the questions of costing and services. In terms of healthcare providers, the answer is that it's having a kind of quite a dramatic effect, and I think it's driving migration of specialists out the country, and obviously remuneration will change, in terms of this, the question of autonomy at the moment, yes, people can do anything. But if you look at the health market inquiry, and we haven't spoken about that at all, we've seen very slow traction of the implementation of the health market inquiry recommendations from both government and to a large extent in the private sector, although there have been some initiatives. And those health market inquiry recommendations would also have an impact on how private doctors operate and manage. And I think we have to look at it. There's massive over-servicing and use of expensive tests when simpler, cheaper ones would be as effective. So I think it will certainly impact on total earnings, on autonomy. But the question is there a balance where you can sort of still ensure good remuneration and good autonomy as a professional while setting frameworks and boundaries? And I think as a country we're not doing enough to reassure our medical specialists in particular that there's, it's taken them 15, and if they're subspecialists, like if I use the example again, nephrologists, 17 years to get to that point of practice as a specialist or subspecialist. I think we're not doing enough to reassure specialists. Remember that in South Africa today, we already have a massive shortage of specialists. The Percept work did it. We did some work in the Human Resources for Health Plan 2030, we generally have somewhere between about an eighth and at best a half, but usually about a quarter of the specialists we need in each discipline in the country to provide adequate care. So we spend 17 years helping people to get there, and then we don't make enough effort to retain them in the country against a global shortage of specialists where all countries have abandoned, a whole lot of countries have abandoned their commitment to the WHO compact on ethical recruitment, and they are headhunting heavily everywhere, and that needs to be addressed as well, because our specialist shortfalls are going to get worse, not better.
I think there's a question kind of linked to that conversation. You've touched on a few things. I mean, maybe just to position what's not often said, and you've said it here twice, is that private patients do sometimes use, particularly the academic public hospitals. So that is a key point. But I think it's also the reverse. So there are those that are not in medical schemes and quite a large portion that use ad hocly out of pocket the private sector. So there is a nice, or there's kind of both sides of the story. I suppose in the private to public it's often more the academic hospital level kind of complex issues, whereas public to private might be more the primary care level. But not always, but certainly there's that both sides. So Professor Buch, but I'll probably position this perhaps to Mr. Donaldson and then to Mr. Rensburg, but you said a strong thing. You said there's lost trust in the private sector. Now, the one thing, some of the argument or press releases that I've read talk to the issue of the kind of incomplete medical scheme regulatory environment. You mentioned the health market inquiry. We also have primary care insurance products that are in an regulatory exemption spot. They've been ring-fenced. There can't be new entrants. They can take on new policyholders, but they're kind of protected and they're kind of in this exemption position at the moment. So you've got kind of incomplete regulatory structures in the primary insurance, and medical scheme environment. One of the positions I read was that the NHI fund has good things, as Professor Buch pointed out. The kind of strategic purchasing. These are things spoken about quite often in the medical scheme environment. So split the pooling to the purchasing. So contract for quality and outcomes, etc. So some of those sort of mirror each other. So that kind of concepts come through quite nicely in the NHI fund. So the ability to dedicate funds to healthcare, strategic purchasing, etc. So that's all. So that came through quite nicely. But let's talk about the the health market inquiry, the medical schemes. So the argument I've seen in the press is certainly that that's been under the purview of the Department of Health and Government anyway. But it got stalled a couple of decades ago, and certainly everyone accepts that there's inefficiency in that space, and we've touched on that. So perhaps, I'll start with Mr. Donaldson and then to Mr. Rensburg, but just what's the next steps in the medical scheme regulatory environment or the primary insurance or both, given the context where we're at?
So I think the next steps are to go back to some of the incomplete reform processes that got underway in the 1990s. So Tamar Khan and I wrote a paper which is published on the Economic Research Southern Africa site, where we essentially argue that 2007 and the adoption of the NHI proposal that made its way into the Green Paper and the White Paper and then eventually into the Act now was not the original plan. The original plan, as recommended by the Committee of Inquiry that was chaired by Broomberg and Shisana in the 1990s, and was elaborated in quite an interesting set of proposals in the Taylor Committee report in 2001, involved a continued prioritization of primary care as the public as the public sector's responsibility, alongside an expansion of medical scheme membership, with hospital insurance continuing to be kind of jointly financed. Now, there's a lot more to it than that, but that's a reform strategy that recognized that making the leap from the sort of bifurcated system that we have now to a single fund was unrealistic. That you had to have a strategy for getting there, and that strategy for getting there would involve expansion of medical scheme coverage. So that means the risk equalization fund gets implemented. It means that progress is made towards a low-cost cover arrangements that perhaps blend public and private services in some respects, alongside the full package of services that is built into the prescribed minimum benefits. It means implementing some of the reforms that would allow the private service providers, hospital groups in particular, to contain costs. So private hospitals should not be barred from employing medical professionals. It just creates an incentive structure that drives up costs. You have to do more work to ensure that the technology assessments and that can contribute to containing costs, that case management arrangements are put in place. There's a regulatory framework behind that has been left undeveloped. So with Medical Schemes Act, this regulatory framework has just not been amended and revised and strengthened over the last 20 years. And there are elements, and Eric talked about this, of that strategy envisaged in the late 1990s, the hospital strategy project, for example, that were about reforms in public health services that would enable them to get closer to being able to do contracting. So Eric talked about contracting relationships between a central fund and public hospitals. Well, you can't do that in the present arrangement. That requires institutional change in how public health services are organized that takes you in some respects towards leveling the playing field. And then I would add to that there are lots of things that could be done that cut across the public and private sectors. Competition in health laboratory services, competition in radiology, and things that essentially the public and private systems buy, but buy in separate systems now, create competition across them, make progress towards a system in which the huge institutional imbalances between these two different arrangements begin to be bridged.
Thanks. Maybe can I quickly pass one question and I'll go to Mr. Rensburg. Just, Mr. Johnson, do you think there's a viable coexistence or integration of medical schemes to the NHI? Yes. Or does it have to all be scrapped and start again?
Oh, I absolutely think there is. I think that, and the starting point of that is the idea of a standard-based package, which is one of the key recommendations of the Health Market Inquiry, that needs to be visible and transparently incorporated into medical scheme packages in a way in which you can compare across schemes and that is funded in a standardized way. That initial package that is collectively funded might be quite limited to start with.
And is that across the NHI as well? A consistent package?
And it becomes the base, but you've got to make progress towards a package that can be delivered across this, and that can take advantage of the delivery capacity of both the public and the private sectors. That might be centres, that might be GP groups that are in the private sector, or clinics that are in the public sector, over time remunerated on a similar basis.
Okay, Mr. Rensburg?
I agree. Look, I think all the things happen on Monday. Right? It can't happen on Monday. It's an incredibly complex system. Right? I think publicly my position has always been a unified system, or a system operating in a unified way. Right? I'm agnostic on a single funder in the short term, because I don't think it's feasible or practical. But I do think that if you consolidate public sector financing, right, and how we fund provinces, which I think a large part of the Act does, it separates that purchaser and provider in the province. Now, currently the province is the provider and the purchaser. So each of the 9 provinces set up their own prioritization criteria. Or like it follows like infrastructure inequity traps, where you end up funding the infrastructure that's already there. And I think the result is like 65% on hospitals and specialized services. So in the short term, you could have a single public sector fund that could get all of all the benefits that are described through a single fund look, I forget the technical terms. You can still drive down costs. You can still improve efficiencies. You can still improve accountability. But the difference is that everybody else has to be on the same unified progression pathway, right? So if there's a base package that everybody can get in the public sector, in the short term, everybody should be able to get that. Medical schemes can compete on costs, and they can add things for people that want additional access. They want a platinum hip rather than a titanium one or whatever. I'm being simplistic. But the path at the moment is we have to improve the efficiency of the public spend. And I think we do that by consolidating the funding, shifting the funding to where the services are delivered, creating new opportunities for healthcare professionals, right? So you could have a network of healthcare professionals working in a CUP, within a district hospital. In theory, a district hospital could be run by a private group of practitioners if the province decided to contract that out. So the entire implementation framework can change. But we're not going to take away from the fact that the state has an obligation to provide healthcare services. The gap at the moment is it can't afford free healthcare services all the way. And the free package is the bit that I think we need to figure out, and then we can figure out how people pay for services based on need at higher levels of care. right? So at the moment, I can be on oncology treatment at the moment, the highest package at a medical scheme, and I lose my job, or I get bored and I can no longer afford that medical scheme premium, I will go into the public sector, right? But for free, even though I have some benefit to pay, whereas in rural Garankuwa, a woman can't even get a scope or a basic preventative stuff for cancer. So there's all of these inconsistencies where on the one side we have world-class care, on the other side we have no care, right? And then the public sector also carries the vast majority of the end-of-life costs because they can't turn people away. They can't say, you've reached your 150,000, please move on, right? They have to take those patients. And I think by the regulatory framework comes with that base package, and then we regulate how everybody else operates around it. The current position is not sustainable.
Thanks. Ms. Buthelezi?
Sure. I think I just want to come in on this point too, because yes, agreed, base package is important, and that being transparent and applicable was quite a key recommendation from the HMI. But I think importantly, what is always lost from the HMI's recommendations is that the HMI did not present a world of either or. It was actually a world of a complementary usage of both the private and the public healthcare systems in place. And what else the HMI also spoke to is the fact that there is a lot within the public space that may be efficiencies realized without the need of a single fund. So the use of regulatory tools such as mandating collective bargaining to almost leverage from the big size that government has, but without, the very stringent legislative requirements and change in funding model that the Act is speaking through now. So there is a lot that can be done. Reimbursement mechanisms was another big part that the HMI talked through and actually spent a lot in terms of the regulatory framework behind that. So I think there's a bit of a danger of an either or, and there is still quite a lot that can be done in terms of the regulatory compliance, which could assist in getting through all these public efficiencies that we need, but also correcting for some of these private sector inefficiencies that are in place to further support everyone.
I do want to give Professor Buch a chance, and then I do want to give the audience a chance. So we are running tight on time, so Professor Buch.
Which question do you want me to answer?
I think there's been quite a wide discussion now, touching on most topics. So if there's anything you'd like to add, otherwise I can move to the audience.
I mean, we've got very little time. Why don't you go to the audience?
Okay, happy. Okay, time for the audience to pose questions. If I can see, I see a hand in the passage there and one up here. Start here.
Hello. Hello, interesting talk. I mean, before this, I had a different idea of how the NHI works, but just listening to you guys here, it's kind of concerning. I think maybe if we get a bunch of actuaries to go there and discuss what should actually occur, because the more we talk about it, I mean, it just doesn't make sense. If you have a household with 4 kids, and you can't afford the comprehensive package, you'll get a cheaper one for everyone, right? So, including the 350 grant, one could argue, is that enough? But they're getting it if you're not employed. So, I think the question really is, what is the minimum benefit that we should actually get? And why is it that we're still discussing it? I mean, it doesn't even seem like it needs the private sector to fund it, because it's not like you're giving a hospital X amount of money or whatever the money is. The idea is when someone does go to hospital and there's a cost, they can be billed for it. I mean, we all pay UIF here, but not all of us are taking those benefits. So it just doesn't make sense to me that why we're still talking about it, and why the minimum is not being implemented as yet.
Mr. Rinsberg, yeah.
I'm going to rush in, I must be the fool. But look, I think at a base level, when the WHO talks about universal health coverage, they identified 3 different priorities, right? So the first one is maternal and child health services, right? So everybody's going to have a baby, go to hospital, the baby needs vaccinations, the mother needs sexual and reproductive health services. Those are basic stuff that everybody must have, right? So that would be the first part. When we calculate what the equity is, and that is, they use a thing called effective coverage. right? So effective coverage is when 80% of the population at risk have the benefit of that service, and then it has a population health impact. In our current system, the benefit is there, but it's not equally available to everybody. So in rural areas, the outcome of that would be that maternal mortality is higher because mothers can't get to antenatal care because the current delivery mechanisms doesn't really reach them. So instead of going for 7 visits, they go for 1 to confirm their pregnancy, or maybe 2, the second one to confirm a bed, or the child doesn't get all the different vaccinations that they need. By creating that as a package and saying that, look, anybody can deliver it within that framework, you can expand access to that bit. Then you have infectious diseases. So with HIV, we're kind of in effective coverage at the moment. We're over 80%, we're close to 90%, but we have to keep all that people in care. The benefit is only there for as long as we're able to retain them. So at the moment, we're good at getting them on, we're not good at retaining them. So can we figure out how we solve that problem better? Is there a mixed model delivery system that we could do differently if we had different financing? And then we can expand coverage and maintain effective coverage and improve population health. Tuberculosis, same thing. Anybody can get it, but mostly poor and people on the margin get it. Their access to healthcare or their patient experience is different. What if we universalized access and said I could go to pharmacy X and get my TB test rather than go to the clinic? The current arrangements don't allow for that. The NHI arrangements will allow you to contract that in, right? So that's an improvement on what is there. The last bit is the things that we're struggling with, right? Both in the public and in the private sector. We used to think there was a healthy young, now there isn't anymore because of non-communicable diseases and the kind of things that are there, from anxiety to depression and other mental health issues that we haven't begun to scratch the surface. Then there's issues of diabetes, like I mentioned earlier, where we need to expand coverage, otherwise it's going to cause more people to die. Then there's issues of cancer, where access is actually very, very limited. And I think we need to look, those are the base packages. Anything above that, like emergency services is expensive. Emergency services in the government parlance at the moment, we just think of it as access to ambulances. But are our accidents and emergencies up to scratch? Can we improve what the basic package around that should be so we can fund it better, so we can get better professionals? So I think that's where we start. The additional stuff is like some things that can be free for some people, like cancer care. For other people, because of the ability to pay, they should be able to have a co-payment, right? And then how we expand that and where the multi-funder environment in the medium term comes into play is what people can provision to do that. But the base package is those 3 things, right? Having some kind of response to it. And then there's broader responsibilities that the state will still have to do. It still has to regulate. It still has to fund the training of healthcare professionals. It still has to invest in infrastructure. How those infrastructure can be funded can maybe be different because there's a return on investment that can happen. So I think there's lots of different possibilities. But there is a base package. It's not universally available. There's inconsistencies between public and private. And I think starting with one that everybody delivers improves for everybody, right? It's just where the access point is. But ultimately our goal is to improve coverage on essential health services and over time expand it.
Thanks. Mr. Donaldson?
Can I say something about affordability of cover for a middle-income family, 3 or 4 people? The medical scheme costs going too high, so you look at opting for something that's cheaper, hospital plan maybe. And now there's a worrying fragmentation in the broader health insurance market, because medical schemes have become more expensive, and the regulatory reforms of the 1990s that created much better risk pooling and sharing of costs in the medical scheme environment have not been continued, have not been completed. Risk Equalization Fund is one of those. So there is a worrying trend in the emergence of these alternative, what I call shadow products that has to be addressed. But affordability is going to be about other things as well. So we've had the Health Department present to Parliament in the last couple of days a proposal for phasing out the medical scheme tax credit. That's the opposite of what we should be doing. First step in making medical schemes more affordable is to make the medical scheme contribution tax credit creditable, that is to say refundable, that is to say that if you're below the tax threshold, you get it in cash or it goes to your medical scheme, which would be a further step in making it a redistributive mechanism. And then think on this. The medical scheme's tax credit that allows you to include your children as additional claimants in your system is the only thing in our tax structure that recognizes the duty of care of breadwinners in families to their family members. We used to have a child allowance in our tax system. We took it out for simplification purposes in the 1990s. It's probably time to bring it back now. It's probably time now to make another change to a change to our personal income tax system that recognizes families and the redistribution within families as a social responsibility that should be incorporated in the tax structure. Then we need to make progress on medical schemes that are properly regulated, that are affordable, a low-cost scheme that includes some combination of public and private services in all probability. And we need a deliberate strategy for expanding coverage and recognizing that expanded coverage in this system over time reduces the burden on the public health system and allows both systems to provide services on a more equitable basis. But that needs to be a national objective to expand coverage and make coverage affordable.
Maybe we are out of time, but I'd like to ask, I suppose, the audience and the panelists permission just to do 5 minutes, just get 1 or 2 more questions, just because it was quite a wide question and we had wide answers. So if we're fine with that, 5 minutes, it's a longish tea break, so I'm sure we'll be fine. And this is a unique opportunity. So can we have 1 more audience question?
I've got a mic here.
Oh, there we go. Thanks.
So I'm from the Eastern Cape, and the hospitals and clinics there, it's a disaster at the moment. I can tell you stories after stories. And everything here sounds very far away, there's not a clear framework yet. Is there anything in the short term, 3 years to 5 years, that government's actually working towards? Because I just read about corruption and this one stole this from this hospital. Is there anything that's in the short, medium term actually going to help the public hospitals that you guys know of? Because, you seem very clued up.
Just 1 minute.
I was the spokesperson
just
of
1
the
minute.
National Department of Health. But look, I think at the end of the day, if you look at healthcare funding, and I'm going to blame Andrew and his crew there from Madiba Street in terms of how we funded healthcare. We've got structural inefficiencies of how we fund it. The Eastern Cape, for me, is like a case in point. I published an opinion around this. They have 80 district hospitals for the same population that the Western Cape serves with 20. Right? So just looking at the amount of hospitals, they should be rationalizing rather than expanding. But there's no incentive to do it. Right? Because the current systems just work on historical expenditure, and all they do is just top up your budget from the previous year. In the short term, I think the special appropriation bill that came out today, or at least was discussed in the Appropriations Committee today, gives us some insight into the things that we need to do. Right? As I indicated earlier, if we don't fix the response or stabilize the response to HIV, then everything else, all bets off. Because it's shaped the public sector response since its emergence in the 90s and in the 2000s, like fast 6 million chronic patients. I think that for the Eastern Cape, the first step is rationalization, and I think they have a plan. The second step is really to start thinking about a funding model for hospitals. The current model we have is not sustainable, right? And we are literally going to just have buildings that we don't invest in because HR costs go up. Maintenance has been neglected for a long time. But I find hope in the changed political economy. I think we should be placing a lot more pressure on our government, which is no longer a single-party government. It's a government of 10 parties with diverse views. They have a responsibility, primarily through the budget, to make the short-term provisions that are needed. What we need, though, in the short term is a bailout of provincial entities to get rid of the historical spending. They're carrying up to 10% of the total budget in accruals. So when their financial year starts, they've already lost 30% of their budget. Right? And I think if that's the case, you're going to a highway down, right? So we need an intervention like SAA and all those guys got. We need Andrew and all the other clever people in the system over time to maybe put together a nice transition panel and then come up with a different way to fund hospitals. Until we do that, we're going to have more of the same. And I think that's why the NHI reforms, particularly in the public sector. And I hasten to add that 98% of that bill is about the public sector. There's one clause that talks about the private sector. Right? So I think we need to invest in strengthening all of those things, but we can't continue in the way that we are.
So your question was the next 3 to 5 years. So the first thing is the emergence of the Nelson Mandela University Medical School, because that will certainly lift standards and also retain, you're more likely to stay in the province in which you're trained. There's good evidence for that. The second is that the provincial head of the Department of Health has got a very impressive plan for turning around a lot of the problems and inefficiencies in the system, and if she's given the opportunity to implement it, I think that will make a huge difference, Dr. Rudin Wagner. And I think the third is that the Eastern Cape needs to get a bigger slice of the health slice. I know it's, in big budgeting terms, it's the proportional allocation of the province, and the province can decide. But guys like this in the Treasury tweak that along, and the Eastern Cape needs to get a fairer slice of the budget. There are a whole lot of other factors that have to be dealt with, like accruals, like the medical legal malpractice and the measures for that. But that's your answer.
Thank you. I'll do one more question, but I think it's some leadership skills, governance, training, funding. Last question.
Bit of a basic question, so I understand the funding part in terms of equity and split, but from a physical infrastructure perspective, what's going to happen? Are private hospitals going to remain private? Are public hospitals going to be competing private hospitals? What's that landscape look like? And then the second question is, even as someone who's middle income, sometimes you go to a private hospital, and then after your operation, you find out that, oh, hey, you have a shortfall that you have to pay because the specialist is charging 500% above the medical scheme. How are we going to address that?
Well, yeah, I mean, look, there are a number of things. The 500% above, you must blame that on the Competition Commission. And in the health market inquiry, they wanted to go back to so 20 years ago, roughly, they said that the system where government, SAMA for the medical specialists, the Hospital Association, and the Board of Health Funders got together and they agreed on what were fair prices to be paid for all the services. And the Competition Commission, in its wisdom 20 years ago, said that that is anti-competitive and illegal and threatened legal action against them if they didn't stop. And that meant you had and their understanding was that that would drive prices down, because that was their thing, competition. But they failed to understand health economics and the health sector and the shortages. And now, previously, if a doctor charged 500% more than the agreed tariff, they would be in front of the Medical and Dental Council for unethical practice. Now you can charge 1,000% above the practice as long as you tell people in advance and you've got a shortage of supply. You will go wait 3, 4, 5 months for an appointment. So that's the answer to that. In terms of the public hospitals and the private hospitals and how it'll unfold, that's a long question around the aspects of how the NHI gets implemented, how private hospitals are part of what's contracted, who gets to choose whether you end up in a smart private hospital or all of these questions. If you're going to have a cup of tea, I'll have a cup of tea with you and you can answer that.
So I think I need to end it there. I think we've seen the complexity in trying to get aligned ideology, collaboration, trust, technical work, on-the-ground practicalities, money, operational capabilities, all of those exist. So I think our challenge to us as actuaries is how do we support it, positioning ourselves to try to be impartial, professional, and provide technical expertise to kind of get better collaboration and engagement. So That's what we're trying to do in the background. That's what we're listening to press shouting number. But hopefully that's our challenge to all of us, and hopefully we can try hard. So, thanks very much.
And thank you so much for that conversation. If everyone in the room doesn't mind giving us just a second to share some logistics of what's happening post this, we really appreciate it. So next up we have a refreshment break that's brought to you by Communicate Recruitment. If you're hiring, exploring your next move, or want insights into the market, please go say hello. They'd love to speak to you. If you enjoyed the nail-biting chess semi-final, just wanting to let you know that remember to pop into the chess tournament area in the semi-final showdown in our Insight ASA Convention chess tournament, where the chess maestros will face off again. And the next thing that you need to be aware of is that from an exhibitor perspective, see what's new this year. Momentum is running a paddle tournament. Standard Bank is bringing the acceleration of a Formula One simulation course. But don't worry, all of these are virtual. So you are absolutely welcome, and we're keen to see actuaries have fun. Head over as well to Platinum sponsor SA3 and chat to them about how to pursue your dreams with passion. And while you're at it, stop by Discovery and WTW, who are all set and ready to serve you delicious coffee, or if you're going to take the prof up on a cup of tea. After the break, please make sure that you join us back in Ballroom 150 for a session that's titled Universe on Stage, which is going to be done by Dr. Lucia Pantija, I'll find out after, as well as Yashin Modi. That will promptly start at 4:35 in the main Ballroom 150. Thank you so much for joining this session, and we will see you after the break.